Right, welcome to this lecture on diabetes pharmacology. I recognise it's not the most exciting of subjects, but it's absolute MCQ fodder and it comes up every year. Generally, the questions aren't that hard. It is things like what class of oral hypoglycemic agent is metformin, or a lady is concerned about weight gain, which of these diabetic medications should you not use? So we'll cover type 1, we'll cover type 2, we'll cover the pathway in type 2, and obviously we're going to go through the medications in each. So first of all, type 1. I'm not going to bore you with the pathophysiology. I'm just here to talk about the pharmacology. So the basal bolus regimen is the gold standard. That is the one where you do an injection at 10 p.m. at night or just before bed of a long-acting insulin, and then you do a bolus, which is a short-acting insulin before each of your meals. 30 minutes before each meal. There are different insulin sort of regimens as well, but so things like a twice daily mix or a BD mixed regimen, that is no longer recommended. That is the one where you will inject twice a day, a mix of a long acting and a short acting, such as Nova Mix 30. That is not used in type 1s anymore. The reason we use basal bolus is twofold. It more closely mimics the natural endogenous insulin production, and also it allows for patient autonomy. And by that, I mean the patient can choose how much insulin they inject themselves depending on how calorific they think their meals are. A big thing that NICE go on about is in diabetes is patient autonomy and individuality of each patient. So there was a study called the Daphne trial, which looked at sort of dose adjustment in patients' normal eating, and it gave them scope to adjust their doses. And what this basically found was there was much better glycemic control, and the patient's overall well-being was better. One thing to note, NICE recommend considering metformin in their type 1 if the BMI is over 25. I've never seen this happen in real life. I doubt you will either. And you should still use the HbA1c as the target. So it should be measured every 3 to 6 months. Target HbA1c of less than 48. We'll come on to that a bit more when we talk about type 2. Now, the insulins, obviously given subcutaneously, their side effects are hypoglycemia, and also a thing called lipodermatosclerosis. That's a fatty deposit buildup at sites of repetitive subcutaneous injection. Problems with this are, first of all, they're anesthetic. Secondly, they can be painful when you inject into them, and also they reduce the insulin efficacy because the insulin actually accumulates in these fatty deposits. Two types. So the long acting, I will only ever talk about brand names. It's like asthma. You're supposed to use the brand names of everything. So Lantus and Levemir are the two long acting ones that you'll hear most of the time. It's good because they both begin with L and they're long acting. As mentioned earlier, take them at bed. They've got a flat curve of action. They work over 24 hours, and they do that because they are recombinant insulin analogues. That means they are made by bacteria and they're genetically modified. So what they do is, in an acidic pH, these insulins stay soluble, and so they are stored in an acidic pH in a vial before injection. Then when they reach the normal pH of the body, they slowly precipitate, and that's what causes their action over 24 hours. To note, Toujeo is a newer, longer acting one. It is exactly the same as Lantus, just it's much more concentrated. So in someone who's got really poor control, who needs lots of units, it's much better because it reduces the actual volume of injection. Short-acting ones, Novorapid, Humulog, onset is within 30 minutes. This is really important because that's why you tell the diabetic, inject 30 minutes before your meals. And also, when you graduate and you start seeing hypoglycemia on the wards, sometimes it's treated with a short-acting insulin. And basically what this does, well, the important thing to remember is not to check the insulin too soon, or the BM, sorry, not to check the glucose too soon, the BM, because it takes 30 minutes for these medications to reach their peak of action. When else do we use insulin? Sliding scales, now known as a variable rate insulin infusion. During pregnancy, if they can't during pregnancy, if they've got gestational diabetes not controlled by diet alone, in hyperkalemia. So, HbA1c targets. I'm only going to talk in the new units, which is millimoles per mole. Percentages are now wrong. You shouldn't use them. So, diabetes is diagnosed at an HbA1c of greater than 48. Pre-diabetes is 42 to 48. So, type 2 diabetes, the pharmacology can be confusing because there's so many different drug groups. I like to think of them as seven individual groups, but then let you use them in 3 stages. First stage being metformin, second stage being the middle 4 sulfonylureas, gliptins, which are DPP4Is, pioglitazone, and SGLT2 inhibitors. And then the third stage is your GLP-1 mimetics and insulin. Now, importantly, in type 2 diabetes, we all know it's a combination of insulin resistance that builds over many years and also impaired insulin secretion. So the patients are obese and they usually present in older life, and as the pancreatic sort of beta cell production wanes. And to note, by the time it gets to the late type 2 diabetes, that beta cell production has waned so much that there is hardly any insulin production. So medications such as the sulfonylurea, which increases insulin production, is not going to be effective in late stage diabetes. So the pathway. You diagnose them at 48. Your first stage is lifestyle modifications, looking at a target of 48. You then review them in 6 months' time. If they haven't reached their target of 48, you move on to the second line. That second line is metformin. You still use 48 as a target. Now, you only add a second drug after metformin if the HbA1c then rises to 58. So just remember the 8s as when you add in a second drug, another drug. If you review them after you started them on metformin and their HbA1c is say 53, i.e. it's only risen by 5, then you need to increase the metformin dose. Now these are guidelines. NICE makes a really big thing of making the targets individualized to the patient, their preferences, their comorbidities, their occupation. But in general, these are the guidelines, and these are that get used in any like MCQ or OSCE. So first of all, metformin. Apologies for my pronunciation here. It's a biguanide. I still don't know how you say it. MCQ questions are as simple as metformin is A, and then answer A, biguanide. So it works by activating AMPK in the liver. AMPK is a enzyme which itself inhibits gluconeogenesis. That decreases glucose production and therefore that improves your glycemic control. It also increases glucose uptake and sensitivity to insulin and has a range of other effects as well. So it's really a really good drug. Doesn't cause hypos, doesn't cause weight gain. Its problem is GI upsets. Very common: nausea, anorexia, diarrhea. To the extent that metformin itself is actually intolerable to 20% of patients. The other side effect is lactic acidosis. And the lactic acidosis is what gives the metformin its contraindications. So any condition which will more likely make the lactic acidosis happen, if that makes sense. So, for example, in kidney disease, that metformin is excreted through the kidneys. That will cause an increase in buildup of metformin, increasing your risk of lactic acidosis. In conditions such as tissue hypoxia, such as post-MI, or if you're in septic shock due to massive peripheral vasodilation, that will cause tissue hypoxia. That itself will cause a buildup of lactate, which further increases your risk of lactic acidosis, hence contraindicated metformin. That's why you're in kidney disease, you stop if the eGFR is less than 30, and review the dose if the eGFR is less than 45. And then when we talk about the GI disturbances, you want to, if they don't tolerate it, consider modified release metformin. Okay, back to the management. So we've added in our metformin. the HbA1c then rises to greater than 58. That's when you add in a second drug, and you can choose any of the middle four. So sulfonylurea, sitagliptin, linagliptin, the DPP4Is, pioglitazone, or an SGLT2 inhibitor. To note, your target moves up by 5 by then, okay? So, first of all, sulfonylureas. This is gliclazide, glibenclamide. Very simply, what they do is they bind to K-ATP channels in the beta cell membrane in the pancreas. Very simply, what that does, that stimulates those beta cells to secrete insulin. Problem with that is it will cause hypos and weight gain because there's more insulin kicking around. These are the dirty old drugs like sulfonylurea that cause hypos, that cause weight gain, and rarely can cause cholestatic liver dysfunction, SIADH. For the reason that they secrete insulin through the beta cells, they're not very good in late diabetes. That's why they're generally used a bit earlier on. Contraindicated in breastfeeding and pregnancy. All of these diabetic meds are contraindicated in breastfeeding and pregnancy, but this sulfonylureas are also contraindicated in liver failure simply due to the rare incidence of that cholestatic liver dysfunction. Clinically, you're not going to put an overweight patient on one of these because it's going to make them more overweight. Next is DPP4 inhibitors. This is sitagliptin, linagliptin. To know how these work, you first need to understand about incretins, most famous incretin being GLP-1. So incretins are a group of metabolic hormones. They're released after eating, and basically they increase secretion of insulin through stimulation of beta cells and also reduced glucagon production from alpha cells, both in the pancreas. Right. Overall, that contributes to a decrease in plasma glucose. That's what incretins do. Problem with incretins is they only last, their half-life is around 2 minutes. They are then metabolized by a enzyme called dipeptidase peptidase 4. Dipeptidyl peptidase 4. Sorry, DPP4. DPP4 inhibitors, such as sitagliptin, just competitively inhibit dipeptidyl peptidase, stopping GLP-1 breakdown, prolonging its effect. Benefits mean no hypoglycemia, they're generally well tolerated. However, they are associated with pancreatitis because they work directly on the pancreas, and there is some evidence of renal failure. Clinically, they don't cause any weight change. Next of the 4 drugs which you use after metformin is one called pioglitazone. Now that is part of a larger group of medications, which is that long word next to the pioglitazone, but the only one that's actually licensed to use is pioglitazone. This is another old dirty drug. Okay, so it works. It stimulates the nuclear receptor PPAR. What this does, this modulates transcription of genes involved in lipid metabolism and glucose. This basically decreases insulin resistance and decreases gluconeogenesis. As I say, it's one of these old dirty drugs, and they cause weight gain and hypoglycemia. I'm just trying to get it in your head that pioglitazone and sulfonylureas cause weight gain, hypoglycemia, just because they're not as refined as the newer drugs. Because they have a wide range of nuclear effects, one of the other side effects is fluid retention. That can cause heart failure. There is some evidence that they might cause bladder cancer. For that reason, it's not licensed in France. It's also not recommended at all in Germany. However, there was a meta-analysis, a Cochrane meta-analysis in 2017, which found no difference in rates of bladder cancer. So, the jury's out. For those reasons, it's contraindicated if you've got bladder cancer or uninvestigated hematuria, painless hematuria itself being a major red flag for bladder cancer, or also contraindicated in congestive cardiac failure, that's CCF. Clinically, not used very often, takes a little while to work. You also need to regularly monitor LFTs. That's because one of the old drugs before pioglitazone used to cause liver failure. Pioglitazone doesn't, but you still need to monitor the LFTs. Last one of these four is sodium glucose cotransporter inhibitors, SGLT2 inhibitors, such as canagliflozin, dapagliflozin. Now, SGLT2 is a protein in the proximal tubule of the kidney. It reabsorbs glucose into the blood. This is responsible for about 90% of the kidney's glucose reabsorption. These drugs simply inhibit that protein, stop the reabsorption of glucose. That causes glucosuria. Benefits: it doesn't cause hypos, and that's because it doesn't actually reduce the amount of glucose in the blood. It's simply stopping it being reabsorbed. And so your kidney is never going to excrete too much glucose that's going to cause you a hypo because of that glucose threshold in the glomerular apparatus. Problems though: it obviously causes glycosuria, which is a great environment for bacteria, much more likely to get a UTI. There is also some evidence of osmotic diuresis, just because of the oncotic osmotic pressure of the glucose. Contraindicated, obviously, even though it's a relative contraindication in recurrent UTIs. So we have diagnosed, we've done our first line lifestyle modifications, we've added metformin, HbA1c then risen above 58, so we add in any of those four. If it remains above 58, then either we do triple therapy or we consider insulin. So triple therapy is basically 3 of these meds in a specific combo. This is very complicated. It's much more specific than you'll need for an MCQ, but just quickly, always use metformin, then you use sulfonylurea plus any of the other 3, or metformin, pioglitazone, and an SGLT2 inhibitor. Or you consider an insulin. Now, the insulin combinations are very complicated. You can use a BD mixed, you can use a basal bolus, you can use a one-acting. It is all dependent on the patient's preference, their lifestyle, whether they have whether they eat regular meals, or if they have a job that means they have to miss meals or eat through or work nights, for example. It depends how much they want to inject themselves, what their profession is. So it really is so much variability, it's not worth going into. Now, what if triple therapy fails? This is your end of the line, and very simply, you can go for a GLP-1 mimetic, known as most common one being exenatide. Now, there are some specific factors you need to fill when you get to this stage. That said, if you reach the stage where you fail triple therapy, you will fail one of these. The most important being one, weight loss will benefit other significant obesity-related conditions. If you have failed triple therapy, you will quite likely be obese anyway. And so this last one, the bottom line, you will qualify through it in that. Or if your BMI is more than 35 and you have other medical problems associated with obesity, or if your BMI is less than 35 and you're going to have, and the other option is insulin, in which case that insulin must have significant occupational implications, such as you are a driver or a pilot. Now, if you do qualify exenatide, as I mentioned, it's a synthetic GLP-1 mimetic. Now, this is an incretin. This is what we discussed earlier. So it works by increasing insulin production, decreasing glucagon production. The benefit is that it is longer acting than the real version. Remember earlier I mentioned the half-life is 2 minutes. This one it's got a much longer acting half-life. Other benefit: causes weight loss because it also decreases your appetite. Side effects: subcutaneous complications because it's an injection. There's evidence of pancreatitis. Remember, DPP4Is also cause pancreatitis because they're both working directly on the pancreas. Now, funky picture of the lizard down the bottom is actually a Gila monster. This is where we first found about GLP-1. This secretes GLP-1 in its saliva, and so what it does is it actually paralyzes its prey through causing hypoglycemia, which is just an interesting fact. That's because it's got the GLP-1 in its saliva, which causes the hypo. So clinically, you don't administer it after a meal. You do it once daily or once weekly subcut injection. Because it's expensive, because it's one of these new ones, you have to fulfill certain criteria. these being HbA1c dropped by 11 and 3% weight loss over 6 months. Now, the HbA1c drop sounds significant, but you've got to think about it. These patients often have HbA1cs around about 100 to 120, so actually 11 is not such a big drop. Finally, this is a fantastic BMJ infographic, link at the bottom, talking about all of the pathway for type 2. The only things to mention on here on the bottom right is the insulin program, which is the complicated which program you choose, and also if metformin isn't tolerated. So if it's not tolerated, you do have other options. You can go for any of the other 3 drugs. Just got to remember you have different targets for them, and then after that you then go for dual therapy. So thank you for listening. That is the end.